Hi, everybody. It's Dr. Andrew Gums. I'm here with our 73rd episode of Artificial Intelligence and Cybersurgery. This is the official podcast of our journal, Artificial Intelligence Surgery. And I'm here with my co-host, Dr. Vincent Grasso, who's also a professor of surgery and a professor of computer science. And he'll introduce our next guest. And I'll let you take it. Take it away, Vincent.
Thank you. It's great to be at episode 73. We have the pleasure of having Professor Francesco Giovinazzo today on our podcast. He's a surgical oncologist. I believe you're working now at the Ospedale San Camillo in Treviso, which is a beautiful town in the Veneto outside Venice. And it'd be great to hear, Francesco, what you're doing in your surgical domains and the exciting research perhaps you're doing. So welcome to our podcast.
And before you start, our journal is the first journal dedicated exclusively to artificial intelligence and surgery. So, Francesco and Vincent, you're both founding members of Artificial Intelligence Organization for the Next Generation of Surgeons. Also, by the way, Francesco was at the Consensus Conference in Padua last week. Vincent, you were there virtually. So, just to remind you of how you guys kind of know each other. So, Francesco, please let's find out more where you're from and about your training.
So thank you, Andrew. Thank you, Vincent, for this privilege to speak in this podcast. So I'm, as Vincent said, a surgical oncologist. So I'm doing mainly surgery for colorectal cancer, gastric cancer, liver cancer, and pancreatic cancer. So I started my training in Verona, where I'm from. I worked first of all with a huge unit in a huge unit of general surgery in Borgo Trento, and then I had a PhD with Professor Bassi that Andrew you know very well. Then I moved into in United States for 2 years. So I did some research at Yale, some communality with you, Andrew, in the professor modeling lab,
Oh, you're
studying.
kidding. I didn't realize you were in his lab. Oh, I didn't realize that. That's crazy.
Maybe we met in Yale, but probably
Oh, when
we
were you
didn't know
there?
each other.
When were you there? What
And
years?
I was from 2008, 2010, something like that.
I finished. I was at
Mhm.
Yale from 1994. I'm dating myself. Until 2005, basically. I did undergraduate, medical
So
school, residency, but I did 2 years in Verona with Bassi from 2000 and 2002.
well, at that time I was in another unit, so probably we miss each other for a small
Were
piece of
you were
time.
you in Verona in 2000, 2002?
Yes, so in 2002 I just started my training in Verona. So
Ah, and I
and
just and I just
I moved
and I left.
2008. So we just you leave, I arrived. So we did something
Yeah, yeah.
like that.
Well, it's funny because I broke my arm in when I was in Verona, and I was operated on in Borgo Trento in
Okay.
it around the new year of like the beginning of 2002, around New Year's. I can't remember the date, but it's just funny. We have a lot of overlap.
Yeah, exactly. So maybe it's the time to make this overlap working in a very good way.
Yeah.
So and then I was telling, so I did this PhD. Then I moved to UK for almost 7, 8 years, where I was in the King's College Hospital. Then I moved to Aberdeen in Scotland, and then back to Southampton with our friends Mohammed Abu Hilal. So I
Where
worked
where
with
where did you meet with Southampton?
in Southampton. So yeah,
Ah,
Southampton.
you
Yeah,
know, you
yeah.
know, I
So
just
I
want to
was his
mention
fellow.
that one of our other um, founding members of Aons is a computer scientist at the University of Aberdeen, Professor Elian Ayad. So just you don't know him, do you?
No, no, I know. I met in the conference. So
Ah,
it
okay,
was
great,
funny
great,
because I had an honorary position in his university, the Robert
nice.
Gordon University, but in another school. So there's a lot of overlap and
Yeah,
meeting
yeah, yeah. It's a
with
small world.
with
Yeah,
this
in the
kind
end,
of.
yeah.
And then I moved in Birmingham in the liver transplant unit where I did basically HPB and liver transplantation. But in the meantime, I had even 4 kids. So family, big
Wow.
decision. Where is the right place to live? UK, Italy, and with my wife that she's from Verona. So we decided to move back in Italy.
Are
So
you
in
are you Aston Villa or Birmingham City?
Birmingham City. So Queen Elizabeth Hospital. So.
No, I meant
Oh,
the so the soccer
the soccer.
team. The
Ah,
soccer
okay.
team.
Yeah, it's fine. And then I moved to Gemelli in Rome, which is, it's a big hospital. Probably to this day is one of the most important oncological places in Italy. So they have
Yeah,
like
I saw you
61.
there about 2 weeks ago. I was very impressed with the size. It was really massive.
Yeah.
I didn't expect that.
61,000 of oncological patients every year, which
Yeah.
is like a city. So
It's like it's a little bit. It's still not as big as MD Anderson, but it's
it's
it's in the
growing.
same chapter. It's the same
Okay.
same
Which is
same concept.
amazing, for an Italian hospital where we are like 50 million, so it's not,
Yeah,
it's
exactly.
not
It's
typical
massive.
for Italy. But I can tell you, so the referral in Rome in the Gemelli is probably from all the south of Italy, so all the population are going there. Anyway, I worked there as a general surgeon liver transplant because in Italy it's not still centralization, so you can basically do everything. So from colorectal
Yeah.
to liver transplantation. And then I had this offer to become head of surgery in this hospital in Treviso, which is like how can I say, a semi-private hospital. So we have funding from the government, but we do private practice as well.
It's
Um,
convenzionato.
yeah, exactly. The Italian word is ospedale accreditato. Accreditato means
It,
that
is it
you
like
can.
Casa di Cura Perezzoli? Same type of thing?
Exactly.
Yeah.
Yes, exactly. Same configuration, but my hospital is a religious hospital because the administration are nuns. So basically, it's a bit different in terms of contract, but the meaning is the same as a Pedersoli. And here I'm the head of surgery because we have like the surgical department where we have orthopedics, we have urology, gynecology, and then general surgery, plastic surgery. So there is the services under the big umbrella of the department. So what I'm doing, it's everything in terms of surgery is coming through the doors. So we do benign general surgery like gallbladder, hernias, abdominal wall surgery, and then we do oncology, so colorectal, liver, mainly colorectal and liver mets. So that's the main
Mm,
business.
good, good, good.
Um, we are thinking about starting a pancreas program, but the main issue with the pancreas is that probably we don't have enough resources to
Deal
run
with
the
the
service.
complications.
Yeah, exactly. Because complication, IR,
That's the that,
endoscopy.
that's the a lot of interesting papers about that the results from surgery are equivalent all over the place, but it's the rescue that is the problem is, if the hospitals don't have the resources to treat the complications, that's when, the outcomes
Are
fall. That's
getting
the yeah.
And the question, why am I interested in artificial intelligence, right? So I have to tell you that when I was at Yale with modeling, there was this guy from Russia. He was Ignat Drozdov. He was a physics, an undergraduate in physics, that he was starting to do machine learning in 2008 and making prediction for neuroendocrine tumor. So they made a panel
Nice.
of genes. At that time, there was like this huge effort of transcriptomic and things like that. So they make this panel that is still working, panels, making prediction about metastasis in neuroendocrine tumor. And I was very surprised with him. Why? Because he explained me. He told me, this is the same principle how people they can predict how they are going to the moon or they are going to another planet. And I start my interest in this. And I think with was in 2008 with Mo Abuilal and Mark Besselink, we published a paper based on machine learning and prediction of pancreatic fistula. At that time, this paper showed that we can predict with the two different values in the first 5 postoperative day a clinical relevant pancreatic fistula with like an accuracy of 99%.
What data
So
points did you use for that?
is the Amsterdam and Southampton data. I had all the Netherlands data, and we put together. We did a random tree analysis with the guy that is in New Zealand, but he's from Vicenza, he's a Veneto.
Yeah.
And, we did these things. Then we have not an issue, but, at that time it was very uncommon speaking about machine
Yes,
learning,
definitely.
prediction, this and that. And then there was this how can I say this tendency saying that you have to do pancreatic surgery without drain. So one of the big issue with the reviewers was that when we present this data, they were saying, yeah, but nobody take the drain for more than 3 days. So how can I go to measure for 5? So there was a bit, but at the end of the day, we were able to publish. And now what I'm doing is because I believe that this is the future in terms of big data analyzing and prediction model, running management in the hospital. What I'm doing is just studying with the colleagues in Pescara the workload and the performance status of the surgeon during surgery. So we are going to record the physiological stuff like heart rate, respiration rate, saturation, head with the thermocamera. And then we connect with some exercise that the surgeon, he's doing in a wet lab model, but probably the next step will be to do in the theater and see, if we can correlate, if we can correlate the performance of the surgeon, the stress, the residual workload with what is the outcome, what is, for example, bleeding or tissue handling, injury, and things like that. And this system is already in place for example, in warfly pilot, right? So they are using to measure their performance.
I mean, this is such an important topic. I always remember this paper um, where they looked at the regular population and then they looked at CT scan images of adrenal glands of surgical residents, of general surgical residents, and they found that general surgical residents have larger glands, statistically significantly larger adrenal glands compared to the regular population from the stress of being a surgery resident, from the stress of being a surgeon. All three of us know how horrible the stress can be during surgery, and really there's not a lot of money. Such an important topic. Unfortunately, I'm sure I personally know of 4 surgeons who committed commit suicide. I'm sure, unfortunately, you each know of doctors who have committed suicide and surgeons. And the thing that when we first talked about this, Francesco, like a few months ago, I love the idea, but I really wanted you to meet Vincent because Vincent, how can this generate money? How can we get investors to look at this? It's such an important topic, but who's going to put money into this and how?
Yeah, it's very tricky to have investors invest in any healthcare related activity that doesn't have a very easily identifiable return with a code or a procedure, and they generally shy away from things. It's a tricky dance, but at the end of the day, anyone that can document better outcomes, at least in the United States, can negotiate a percentage of savings afforded through efficiency and better outcomes. And so that's the way that they get compensated here. I'm not sure if that model works in the European sector.
Well, that's interesting. I didn't really think about that. I was thinking specifically of um, you're right. I mean, I wasn't thinking about that, but that would be a great thing if you could show benefit, outcomes are improved when you use this. I can't remember what company does this, but they have these programs basically where the operative camera is connected to the head of surgery's phone. And when there's a problem, the head of surgery gets a little text message like, come to OR7, there's bleeding, or what have you. And so something as simple as that, you could come, or say you have this alarm system, the surgeon's getting stressed, and then you can come in, you can go to the young surgeon, you can help them out, and you can reduce complications. You could show a benefit, but of course, the old expression, who watches the watchman? Who do they call when you have a problem, Francesco? But wouldn't it be great, actually, if they could call a head of surgery at another hospital who could come and help you out? Wouldn't it just be such a wonderful system?
Yeah, I think so. And I don't know what's the situation in United States, but the cost of every day, after surgery in Italy, if probably it's in a normal ward, right? So without considering ICU and
Yeah.
all these things, it's like more or less 500 euro per day without doing nothing, just staying in the ward, right? So
In America,
probably
when I used to be there, it was about 1,000, Vincent. You think it's still about that, or you think it went up? It went up, yeah.
went up. So that's for me. And I tell you, my hospital is a middle-sized hospital, so costs are reduced. But probably if you go in Gemelli or in a bigger hospital,
Yes,
the costs are much more, because you have more person.
yeah.
It's everything is growing. Now, if you can train a surgeon and you can regularly assess the performance of the surgeon and reduce the complication, the first immediate stuff that you will see is decreasing in the hospital stay. Because, for example, when I'm doing a right colon, so in my hands or in the hands of my team, a right colon is discharged after 2 days. So and I'm quite conservative because I want to see passing stool or things that so. But average, the median, let's say, is 2 3 days. If you have even a small complication, I don't know, for example, FA in an old patients because
Atrial
small
fibrillation,
leak,
yeah,
small
yeah.
things, so things that you don't have to take back to theater or you do that, something like that. So you just have so this hospital stay is doubling. So every type of complication that you have, you double the hospital stay. So from 2 3 you go up to 7. That's the minimal, and then 10. And so this is cutting at least if you can reproduce the same technique, the same environment, when you know that I'm not stressed because this and that. Because then this I mean, my system is measuring only our system, the system that we are developing with the Chieti Pescara, is measuring only the surgical physiology, right?
Of the
But then
surgeon, of the
yeah,
surgeon.
the surgeon,
But
yeah.
what would be the intervention then? So now the surgeon's stressed. Now the stress is going up. Then what would you do?
Well, for example, you can swap surgeon. So you say, for example, I'm doing right hemicolectomy or laparoscopic right hemicolectomy. My workload is too high to go ahead and just swap with another one and just take a rest. And
That's one of the things that I loved so much about European um, departments of surgery, and is that it's a real team. Vincent, I don't know if you've ever worked in Europe, but in America, it really felt like one surgeon, one patient, like one surgeon owned that patient. And like if there are any complications, it's that surgeon's fault. But in Europe, it's this wonderful team mentality where you're on call that day, it's your patient, but then the next day you go home, and then your team members, that patient becomes their patient. And it's so wonderful because when it's not your patient, you you have a clear mind, you're not biased, and it's much easier to accept the complication, to reoperate on a patient, and it's such a beautiful thing. But it's not like that in America, Francesco. But it would be great if something like your technology or your idea could actually help bring more of a team mentality to America. I think that alone would reduce stress
Yeah,
enormously.
but you know the one of the finding that we found in the preliminary in the pilot study, for example, is that we use this bed for scale, right? That as I told you, they are using in the fly in the pilot of the flight, the war flight. So I say NATO, but I don't know if it's in English is NATO or is
We say
different.
NATO, yeah, yeah, but yeah.
NATO. So it's NATO. So from pilot from NATO. Now, one of the very interesting finding is that with this scale that is going from 0 to 10, where 0 you are confident to do everything, and then at 10 you cannot do anything. And they say from NATO that when you are 7, you just need to abandon the mission, right? Because you cannot carry on. Was that why the system was recording the workload, we were asking, so what do you think is your value for the Bedford scale? So people that were recording as, for example, 7, they were saying, no, my workload is 3. So, which means that this is an objective way to
Yeah,
see if you can do the job or you cannot do, right?
absolutely.
Because
Yeah.
sometimes, so then to answer to the question in United States, right? In United States, probably you can say, look, you every time you do this task or you are doing this procedure, you are overload, right? Your workload, so your physiology is not allow you to go ahead, and that's why you have that complication after perioperative or later, right? Because for example, I can feel that I'm quite confident. My workload is 3, but the real workload is 7. And just go ahead and cut a vessel and make bleeding. You know what I mean? So
Yeah, yeah, definitely.
so there is a very different way to see the system. I think that if the objective is reducing cost and improve, so cost in US, improving patients' outcome in Europe. So because even the
Two
cultural
sides of the
things,
same coin. Yeah.
you can just go in that direction in a way and in the other in another way.
No,
I
I
don't know
mean,
if
it could be a great help for doctors, surgeons, and patients, obviously. So what have you done so far? Can you give us a little bit more details?
so.
Are you putting probes like things on
Yes.
doctors while they're operating, or are you looking at them with a camera? How are you doing it?
So we have three systems basically. We have some sensor that we put in the chest, right? So and they are recording the stuff. Then we have a smartwatch. They are all Bluetooth, so you can test basically even from far away. So I don't know, guy in Pescara and operator 1,000 kilometers away. And then we have this thermo
What do you
camera,
mean?
right?
Where do the surgeon has a smartwatch?
Yeah, smartwatch. Yeah.
Yeah, but is it sterile? How does it work?
Well, we haven't done in a sterile way, so that
Ah,
was done all in the lab. But we can use the chest stuff, right? So that you just put on under
yeah, yeah, yeah.
your t-shirt and then go ahead. And then we have this thermo camera that is recording the facial movement
Yeah.
and the color that you. So the main limitation for this system is that you have a mask and you have a cap in the operative room, so it's very difficult. If you have to record with the camera, if difficult if you have to record with the smartwatch because but you can put the sensor. And what we are doing is
What
just comparing the three system to make working in a surgical scenario.
in I think it's in Karolinska Institute in Stockholm. I don't know if you know, but they apparently they don't operate with masks, right? Because
Yeah.
masks don't. reduce infection rates for patients. It's just perhaps a protection for the doctor, but even that is kind of ridiculous. But they operate without a mask, so maybe this would be perfect in Sweden because then you wouldn't have that limitation.
Yeah,
Or
exactly.
or we should maybe try to get it removed as an obligation that we have to wear a mask in Italy and in France and things like that because it serves really no purpose. It just, especially you have a beard, it must irritate the hell out of you to have a mask.
Yeah, exactly. So, I mean, I think that the first step is making the system working and standardizing the things, right? Because then you know better than me that the variability in the human being is quite wide, right? So, what is true for me is not for you when we are operating. And then we need to even see the influence of the normal physiology. Because, for example, if my heart rate is already 80 because I'm a bit, above or I'm a runner, I have 60. So, that will make quite difference when I'm going to record the system. Or if my level of emotion, let's say, is quite low. So there is something that we have to do. But I think that is the direction, right? So, and whatever is coming, measuring performance in surgery and making better outcome, I think that should be more than welcome, even for investors, even
Well,
for investors.
where do you put the camera? Where's the camera that looks at the
So
face?
no, the camera is just like the normal webcam that you use is on the stuff, right? So you put on and then
Because I
you've
was
got
just
to.
thinking, while you're doing laparoscopy, if you could attach it onto to the screen so it looks right at the surgeon at all times, you can probably get a hell of a lot of information from someone's eyes. If you use computer vision and a deep learning algorithm, you could probably ascertain stress very well. And also, if you use hyperspectral imaging, I'm sure you can tell, flushing or what have you. You could create something, but but that reminds me, the thing I want to talk about, I don't want to do it on the camera. So Vincent, why don't you kind of close this out and then we'll spend the last few minutes talking to Francesco online, okay? So if
Okay,
you have
great
any
idea.
questions for Francesco, by all means, now's the time, Vincent.
Yeah, just a quick question because one of my research projects involves the surgical's responsibility to patients post-operatively. In the United States, there's a 30-day window where you're kind of responsible for things. In Italy, if you perform a right colectomy on your patient, they go home in 2 days. Where does the window end where you're responsible for that patient? Is it 90 days, 30 days, or when they leave the hospital, now they're the primary care physician's responsibility?
So good question, excellent question. So in Italy, you don't have a limited time where you say after 30 days, okay, patients will be not in charge for me. So anytime it's with you. Now the reality is that after 30 days is quite uncommon to see like surgical complication. So probably in the first 2 weeks, what we are used to do is to see back patients in clinic and phone them and ask how are you and things like that. Then if they are fine, they are fine. In my experience, I make very difficult to remember patients coming back after 30 days. So there is, to answer quite straight to your question, there is no rules, but in the reality, after 30 days, they will go back to the primary physician, even if they have a problem. And then there is another things that, for example, if we do any surgery for cancer, then is our duty to give the pathology results. So usually, since we do the operation to when we have the pathology, it's at least 3 weeks. So you need 3 weeks to wait. So these patients in the first months, 40 days are with us for one reason, for clinic or for, like medication, for everything. So first 30 to 40 days, they are with us. And then we'll see as a follow-up. I don't know, because you do follow-up or is somebody else that are doing a follow-up in the United States?
Yeah, we follow up a lot. I mean, the United States, I would follow my patients a lot after a cancer surgery. I would follow them every 3 months, usually for 2 years, and then every 6 months for 2 years, and then yearly after that. But the system it's just a different system. It's
Probably, one of the issue that with these things that you are saying, Vincent, is, for example, in benign surgery. I don't know, inguinal hernia or because there the big issue is recurrences, right? So because if you do like an inguinal hernia repair and then he will recur after 6 months, who will be in charge for that? And it's considered your fault, is a technical fault, is something that, insurance, because I think that the big issue is this. So who is paying for the recurrence and things? So quite tricky, quite tricky. But, for cancer, I'm just feeling that it's difficult to get responsibility for somebody that is after unless you do not do cancer and then they will recur in 30 days, because then there is a huge issue about technicality, what you done, been radical, a lots of question. But in general, probably the main problem of responsibility after 30, 60 days in Italy is in benign, right? Or for gallbladder, if they develop a late stricture, for example, right? So we have a case that he developed a CBD stricture after 30 days. But then, I mean, an eventful surgery, discharge, normal bilirubin, everything. But after 30 days, he had a readmission in an emergency stuff in another hospital. Then they called us saying, and he had a stricture with the stent and things like that. But who is in, it's a technical fault. It's something. And another point, just looking into what you said, is, for example, people that in these 30 days are coming back to the hospital for clinics, and we don't recognize the complication. So we had a case, for example, he came back, so everything fine, blah, 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 so everything right. But then he was readmitted in the emergency and he had an emergency laparotomy. So it's, so small cases, but quite a good problem.
Well, thank you for that. That's it. There's some interesting things we can continue discussing about that whole post-operative experience. But I think we're running out of time now, Andrew. So we'll close off. This is episode 73 of our AI and Cybersurgery podcast. We had Professor Francesco Giovinazzo on, and he's doing really interesting research in surgical stress and other related things out of the Ospedale San Camillo in Treviso. So thanks again, Francesco, for being on, and we look forward to speaking to you some more about your interesting research. Thank you.
Thank you, Andrew.
all
Thank
right,
you, Vincent.
Francesco. Bye, everybody.